Assalamu alaikum wa barakatuh. It's a great pleasure to be with the adult team in my kingdom. So, my case from King Fahad Armed Forces Hospital, Jeddah. We'll have this is my patient timeline story. So, my patient is an infant who was full term, was cesarean delivery at outside hospital, and initially was critically ill, cyanosed immediately after birth, and was having low saturation down to 40s, 50s, was unstable hemodynamic that required starting of inotropes and starting of prostein, and also was connected to mechanical ventilation and without improving cardiopulmonary status. So this is the echo was done in the previous hospital before transfer to our hospital, and showed restrictive ASD with a large BDA. So we accept the case to our center, cardiac center, and we have evaluation by our cardiologists when they do the echo, and they found, confirmed the diagnosis of restrictive ASD, and saturation was initially was 50s and improved to 60s. So the decision with the cardiac intervention to go for ballooning atrial septostomy. And this septostomy was done, and after that we have improvement in hemodynamic and saturation. So this is the echo showing also the improvement on communication between at the atrial level, in addition to the BDA with the starting of prostaglandin infusion. So as we know that we have to have good communication between the systemic and pulmonary circulation on different level, but at least we have to have two. So we have to have good BDA stenting with prostaglandin infusion, and we have to do the balloon atrial septostomy by interventional cardiologist. And we have to decide within the first 1 to 2 weeks to go for the arterial switch operation for this patient. So once we have improvement in hemodynamic or cardiopulmonary status and saturation and hemodynamic, we go down with the prostaglandin and inotropes till we stop it, and we wean also the ventilation, and also wean down and go. Then we extubate the patient smoothly, and we start also the feeding for our patient. Unfortunately, after 1 day of extubation, our patient have rapid deterioration in both cardiopulmonary status, in terms of hemodynamic, in terms of having severe depressed function, having even high lactate up to 13, with metabolic acidosis even 6.8, 7.1, and also lactate was 13 at that time. This echo was fair, reasonable contraction for the echo. So we do the reintubation, we do the escalation of the inotropes, and also we resume the prostein infusion. We do septic workup, and we escalate our inotrope to broad-spectrum antibiotic. With this deterioration, we go for immunomodulator, IVIG, and steroid. Our markers was trending up in terms of sepsis and inflammation. And also we have acute kidney injury and acute liver injury, and also we have coagulopathy. We have multidisciplinary meeting with my team. So we have a good time for the patient to have hemodynamic stability on inotropes and on immunomodulator and on ventilation. A lot of factors, we have to fix it one by one. So our patient, after the second week, we start to have some improvement in terms of clinical and biochemical parameter, and even we have stabilization in gas exchange, and also hemodynamic start, and even we go down with the inotropes. So we ask our surgeon and our cardiologist, we sit together as a team, we do multidisciplinary case conference, and we decide to go for arterial switch operation for such case. And after evaluation of left ventricle function and volume, which we saw the echo and was having good function and also good LV volume. So the patient underwent arterial switch by age of 21 days of life. But unfortunately, the patient having long bypass with three failed trial of weaning from bypass. So the patient connected intraoperatively to the phenoarterial ECMO due to failure of coming out of bypass and having sign of low cardiac output syndrome with severe depressed function and even high lactate, and also despite of high inotropic support. This is the picture of my patient and also picture of my ECMO flow on the first night. Upon arrival from OR, this is where the monitor we have on the right side. So we have non-pulsatile arterial waves due to patient on full ECMO support, and also we have to check also the X-ray for the for the ECMO cannula. So we keep the patient on ECMO for a couple of days, for about 4 to 5 days, and we go down with initially we receive the patient on high inotropic support, norepinephrine, epinephrine, and also Myrnon. And we have also LV venting, so we go down with the inotropes and we keep the patient on Myrnon and epinephrine low dose. And for acidosis, we have initial acidosis, we started to have to lactate get down, and also start to have good gas exchange, and also metabolic acidosis also improved. And also we start, as usual, most of our patients, we connect to ultrafiltrate through the ECMO, and also the surgeon like to put also BD catheter for dialysis. So we are on low dose of inotropes. This is our patient also was connected to a ventilator, open chest, and was on a resting sitting. And we have improvement on the lactate, and lactate was 6, and go down also the lactate was cleared also smoothly. This echo was done on during ECMO, and was also having reasonable also function. This is also another echo by day 3 and also day 4 of ECMO, and we have also in 50% ECMO flow. We have good also good function, and as we see on the monitor we have also pulsatility start to get pulsatility. We have also lactate also start to clear to 2, and we have hemodynamic and cardiopulmonary status stabilization. So we do our review on daily basis. We have to do daily echo with our cardiologist and also our surgeon to review the patient. And then we decide to go to review the patient, and we do the case conference with the team bedside. So we decide to go for clamping trial, and clamping trial was succeed. Clamping trial was succeed when we go with 70%, 50% of the ECMO flow, 50% of our ECMO flow. Then we go down to 30%. So we are waiting the good news, and we do the blood gas was okay, and lactate was cleared. And then we decide to go for decannulation, and it was successful ECMO decannulation, but we left the chest open on low inotropic support. This is the ECMO also of this is the echo of ECMO. So later, 2 days later, we go for chest closure, and 1 week after closure, we go for extubation, and then we go for rehabilitation for the patient in terms of feeding, pain management, and withdrawal management. Especially the patient was in heavy sedation and muscle relaxant. AKI, we kept the patient on BD dialysis for a few days, improve, and then discharge from BC ICU. Then after a few days, discharge also from the pediatric cardiac ward. This is before discharge. We have echo, and we have good function for the patient, and also we have closed ASD. And this is also good function also on M mode with 62%. So what factor contribute to my patient cardiogenic shock? single ventricle with the TGA with the depressed function, sepsis, and also the main cause is the lung bypass for this patient. So can we reverse the shock? Yes, we can reverse the shock by mechanical circulatory support. And this is my team as appreciation. And this is the patient after we 1 month visit the BCICU. And this is timing, teamwork, knowledge, make this stressful event as smooth as possible. And thank you.